Hi, this is Donna Levin. I am the National Director for the Network for Public Health Law, and it is a pleasure to welcome you to the Public Health Law Conference 2021. Thank you to the Robert Wood Johnson Foundation, the Bloomberg American Health Initiative at Johns Hopkins, and Kaiser Permanente for their support for this conference. And we look forward to working with our partners at the American Society for Law, Medicine, and Ethics, and our presenters on the conference symposium issued to come. Once again, we are unable to meet in Baltimore in person, but we have worked very hard to make sure that this virtual meeting is going to be just as rewarding. Along with the incredible myriad opportunities for learning, at this conference, you will be able to connect with each other and even have a bit of fun to combat Zoom zombie fatigue. Find your colleagues, make new friends and contacts, do some speed networking, and look for trivia, guided mindfulness breaks, poster sessions, and several contests with prizes. It is more important than ever for all of us to keep learning, sharing, and collaborating. For almost 2 years, in addition to personally experiencing the impact of the COVID pandemic, all of you public health officials, practitioners, researchers, and lawyers have been on the front lines giving your all to keep our communities safe by exercising evidence-based and well-established harm mitigation strategies. So I have to ask, how has that been going for you? For the collective us, polarization, political misdirection, the ongoing societal and health harming ramifications of systemic racism and massive disinformation have made an already Herculean task exponentially more difficult. Make no mistake about it, we are currently engaged in a battle over fundamental public health authority, with legislation in various states limiting our ability to protect the health of communities and the equitable health of populations in ways that are often breathtaking in their absence of common sense and their potential to endanger the public's health. So it is even more important than ever that you are here and your dedication to keep working through exhaustion, personal stress, and through the social turmoil for the good of our communities is truly inspiring. At this conference, we have a powerful agenda to strengthen our knowledge, our resilience, and our resolve. 40 sessions on a vast array of public health policy and law topics, all centered in equity, and 3 fabulous leadership plenary sessions. Today's opening plenary, led by Dr. Josh Sharfstein, director of the Bloomberg American Health Initiative, explores 3 major health issues facing us now: gun violence, opioid overdose, and structural racism. Delivering our keynote tomorrow is Dr. Deborah Rothrow-Stith, Dean and Professor at the Charles R. Drew University College of Medicine, who has pioneered the concept of youth violence and violence prevention as a public health issue. And on Thursday, be sure not to miss the closing plenary. The next generation of law and policy leaders are coming up, and we will hear from 3 young advocates with a passion for changing the status quo and taking on the challenge of achieving health justice and equity. One final note. The Network for Public Health Law is working with our partners in public health law and practice in an all-hands-on-deck effort to preserve and strengthen public health authority and the ability of health agencies to protect the public's health, as well as address threats to our public health workforce. Please join us for a special town hall session to close out the conference on Thursday from 4 to 5:30 Eastern. This will be a highly participatory session. We will share a brief overview of the current landscape with you and are very eager to hear from you what your experience has been in the limiting or opposition of public health measures and your recommendations for our focus and our strategic path forward. And now it is my great pleasure to welcome Michelle Spencer, the Associate Director of the Bloomberg American Health Initiative at the Johns Hopkins Bloomberg School of Public Health, who will add her welcome remarks and introduce the opening plenary. Thank you, Michelle.
Well, good afternoon, and thank you, Donna. It is my pleasure to join you in this virtual space as we expand our understanding of how law and policy can advance public health and save lives. And these efforts are sorely needed. As Donna said, we see social justice under threat from violence and attacks on women's health, voting, and immigration rights. Environmental justice concerns, including the increase in hurricanes and unquenchable global fires, pandemic-related misinformation that has caused countless lives, housing policies that create conditions for a higher risk of disease and injury, and a myriad of other social factors. We see the impacts of gun violence, the overdose crisis, and food insecure communities. We are aware of the resolutions and commitments to addressing racism, as Donna noted, and even declared racism as a public health issue. However, our call to action is to do more than just to identify, but to use the identifiable tools, such as the law, that allows for lasting change. That is why the Bloomberg American Health Initiative is proud to support this year's conference. The initiative is a $300 million effort based at Johns Hopkins University and funded by Bloomberg Philanthropies to improve health in the United States through equity, evidence, and policy. The Bloomberg American Health Initiative seeks impacts specifically through education, which includes 50 full scholarships a year for degrees at the Bloomberg School of Public Health, through research, including grants for innovative projects, and through practice, including extensive collaborations with public health sectors. And I encourage you to learn more at americanhealth.jhu.edu, or visit our virtual booth. As Donna said, we are supporters of this convening. We have members from our team available to answer questions and to make connections with you. You'll also have the opportunity to join us in our roundtable discussion tomorrow at 9 a.m. And I do encourage you to join us. You may ask, why is the Bloomberg American Health Initiative so interested in public health law? Our view is that the intersection of public health and the law is a vital and powerful place. Public health law brings together equity, evidence, and policy. Legal approaches have had and can yet have enormous impacts on advancing health and saving lives. The Bloomberg American Health Initiative is especially excited to support this open plenary session, promising legal tools for public health progress, which focuses on the specific challenges of gun violence, opioid overdose, and structural racism. It is my pleasure to introduce our moderator for this session, Dr. Josh Sharfstein, who is the director of the Bloomberg American Health Initiative and Vice Dean for Public Health Practice and Community Engagement at Johns Hopkins Bloomberg School of Public Health. Josh previously served as Health Commissioner of the Baltimore City Health Department, Principal Deputy of the FDA, and Health Secretary of the Maryland Department of Health. Please join me in welcoming Josh.
Thank you so much, Michelle. I almost can hear everybody welcoming over Zoom, but I appreciate that. And I want to, first of all, thank you for your inspiring words, and also emphasize your point that if you are out there working in any of the areas that relate to the Bloomberg American Health Initiative, check us out. Those areas are addiction and overdose, environmental challenges, including climate, violence, adolescent health, obesity in the food system. Maybe you want to be a fellow, you know people who would want to get a full scholarship, or maybe there are all kinds of collaborations that are in our future together. So it's americanhealth.jhu.edu. And I'm a little sad that we're not there in person, first of all, to see Baltimore, but also because if it were in person, I was planning to tell all these stories about Donna Levin from when I was her intern 22 years ago. So that, we'll have to save that for a future conference. But they were really some really good stories. That's all I can say. Okay, so now I'm very excited about the opening plenary. All right, I'll tell one quick story, which is that no matter how crazy things got, no matter how difficult things were on whatever issue, Donna had that same calm, approach. There she is, that that she has now talking about things. And I can't think of anybody better. And I really want to thank her for all the work she's done at the Public Health Law Network and the incredibly powerful advocacy that the network is doing on behalf of the field of public health. But she does that with such a calmness that I have always aspired to 22 years later. Okay, so in this opening plenary, I am pleased to moderate a discussion from 3 terrific lawyers who are studying and using legal tools for public health progress. First, I believe we're going to hear from Josh Horwitz, the Executive Director of the Coalition to Stop Gun Violence. He spent nearly 3 decades working on gun violence prevention. In 2013, he helped to found the Consortium for Risk-Based Firearm Policy, a group of mental health and public health experts who examine the intersection of guns and mental health. He is also a very popular teacher of public health advocacy to students at the Johns Hopkins Bloomberg School of Public Health. Because we're both named Josh, sometimes the students email me and thank me for having taught a great class, and I have to admit it's a different Josh. But today, Josh will be talking about a legal tool that is very relevant all around the country to reducing gun violence. After Josh, we will hear from Sally Friedman. Sally Friedman is the Vice President of Legal Advocacy at the Legal Action Center. She leads a team of attorneys and paralegals that helps over 1,500 clients annually to access jobs, housing, healthcare, and other basic rights. But even more, or in addition, I should say, the legal team also trains and advises hundreds of health and social programs and publishes educational materials read by tens of thousands of individuals and really moves the field of public health law. She will talk about legal tools to tackle the overdose crisis. And then we are honored to have Dawn Hunter here. Dawn is the director of the Southeastern Regional Office of the Network for Public Health Law. And so many of you may know her from her work with the network. Prior to joining the network, she served in a number of roles focused on public health policy and health equity, including serving as Deputy Cabinet Secretary in the New Mexico Department of Health. Dawn will talk about legal tools to address racism and advance racial equity. This is going to be really interesting, and I have begged each of the speakers to keep their remarks to about 10 minutes so that we can have plenty of interaction. We hope with 275 people watching here that you stay interested and send us your questions so that we can get as many of them answered as we go along. So with that, we'll turn to you, Josh.
Okay. You guys see my slides okay? Just give me a nod.
Yes.
Fantastic. So thank you for the Public Health Law Network, and thank you to the Bloomberg American Health Initiative for inviting me here today. It's really an honor. I work for the Educational Fund to Stop Gun Violence and the Coalition to Stop Gun Violence, and we do advocacy. We do community, we work with community partners, but today we're talking, I do a lot of work in as a research intermediary in translating research into public health, into public health policy. And today I'm going to talk about one of those areas, extreme risk laws, where we've had a lot of success and some of the work that I think I'm most proud of over a 30-year career in gun violence prevention. So just a little bit of epidemiology. First, this is a number of gun deaths from 2000 to 2019. It's a chart. You can see it's gone up dramatically. This is the latest CDC data. There are additional data out there, but this is the best data we have. And what we don't see is the curve for 2020 and 2021, which will be higher than the 40,000 that we have in 2019. You can also see that suicide is a moving factor here, and that about 60% of gun deaths are suicide. And so while it's extremely important that we think about homicide and other issues, we want to make sure that we're looking at gun violence in all of its forms, which is very, very important. So I do a lot of research translation, and this is kind of a boring slide, but it's actually an incredibly exciting idea. When you think about research translation, you think about what the data says, and can you explain that to policymakers? But what I do with our work in the Consortium for Risk-Based Firearm Policy, which is a group of academics and allied professionals, where we think about what might be, what's missing in the law, what do we need? And in 2012 and 2013, the debate about gun violence, there was a number of mass shootings. I think we didn't talk about self-harm enough, we didn't talk about suicide enough, but there was a bunch of mass shootings, and the discussion turned to mental illness. What can we do about the issue of guns and mental illness? I wanted to do a deep dive on that and think hard about what that relationship looked like. And one of the things that we were seeing is that it appeared that there were shooters who were potentially mentally ill who were doing these mass shootings. And we had this big frenzy of information about that and discussion. But when I looked at the data, that's not what it really said to me. And that's not what it said to our group of emerging experts in the consortium. What it said to me is that we need to think about risk, but that mental illness was not a really good risk, a way to think about how to prohibit firearms, because there's 40 million people with mental illness in America. Mental illness by itself is a very poor look at interpersonal violence. Could we think about other risk factors and new interventions to address those risk factors? And we looked around and we saw some nascent laws in Indiana and Connecticut that were based on civil protection orders, not criminal prohibitions, but civil protection orders, which were there to remove firearms from people at risk of harm to self and harm to others. The laws in Indiana and Connecticut were actually quasi-criminal. They didn't have all the bells and whistles we wanted. They didn't include family members. So we looked at those laws, we applied the best data, and we thought about what might be if every state had a civil protection order, short-term civil protection order, where firearms could be removed from those at risk of harm to self or others. And we wrote a report, we did a meeting at Hopkins, and we came up with the idea to really expand what we called an extreme risk protection order. An extreme risk protection order has a couple of ideas. It's a legal mechanism that temporarily removes firearms from somebody, an individual at elevated risk of harm to self or others. And they're modeled after the well-known structure of domestic violence restraining orders. And we posited that risk factors, that there were some known risk factors that we should focus on, that risk was multifactorial, that we needed some type of intervention that actually looked at case-by-case situation. And so the factors that we recommended were threats of violence towards others, history of threatening or dangerous behavior, current misuse of alcohol, brandishing of firearm. But what we didn't recommend, and we strongly recommend against, is using mental illness, psychiatric diagnosis as a basis alone for one of these orders. We wrote this report. We worked hard to publicize it. And then there was a mass shooting in Isla Vista, California, early in 2014, middle of 2014, where a mother had tried to get law enforcement to remove guns from her son, where she thought the son was acting dangerously, in fact, was acting dangerously, was unable to do that. And the son went out into the campus of the University of California at Santa Barbara and killed 6 people and shot 14 total. That was the beginning of the adoption of our first extreme risk law that we had designed, that included family members, that included lots of due process protection, and was clearly civil in nature. That law passed in September 2014, and at the time, we weren't sure how far it would spread. But it has actually spread now to 19 states and the District of Columbia over the last 5 years. And so we thought about this idea about what might be, how the law can work to help further public health with data that was accurate about risk. And we've been able to spread this law to 19 states and the District of Columbia. We also were very involved in implementing this law. We just didn't want to pass it and say that's enough. Public health professionals have a role in making sure that the systems that are developed will enable the law to work properly, to identify people who are at risk, and also not be overused for people who are not at risk, that the service and what happens with this law is well done, but not overused and not extend, for instance, the carceral state. So that's something we're really concerned about. And through a grant through the Bloomberg American Health Initiative, we were able to do a great website and other implementation activities to make sure that this law was used, but used fairly and equitably at the same time. So just some latest data. ERPOs have been used over 1,000 times in California, a couple hundred times in Washington, and a number of other states. So we estimate that there's somewhere probably between now 3,000 and 5,000 ERPOs have been issued in the last 5 years. You can see in California how implementation has really mattered here. At the first couple of years of the law, there was very few orders issued, and over time they've been used more to make sure that guns have been removed from people at risk. There's some interesting data that's been developed about this law. Number one is this is research from Jeff Swanson, that for every 10 to 20 orders that are issued, 1 life is saved. And Jeff looked at harm to self in this study and found that extreme risk protection orders were very effective. Garen Wintemute at UC Davis, I don't have that data on the slide, but has looked at the incidence of extreme risk laws stopping mass shootings in California, and found that they have stopped, his short study span stopped 21 mass shootings, including school shootings. So if you think that there's a couple of thousand of these being used early in the life of an extreme risk protection order, and you think that for every 10 to 20 orders that are issued, 1 life is saved, we think this has been a very effective public health intervention, and it's just in its nascency. We would like to expand it to more states. But we'd also want to make sure that it's implemented properly to make sure that people who are at risk have lethal means removed when it matters, but that it's not used in places to harass or harm any individuals. So we are really excited about this intervention. Just 1 minute about case studies. This is not true that some people think, oh, isn't this a harsh intervention, or isn't it always adversarial? It's not. In instances of preventing suicide, there are examples of people coming in together, a spouse or a partner coming in saying, my partner needs an extreme risk protection order, and coming in together, holding hands, saying, this is what's best for me now. There's obviously a Maryland example of school shootings that have been averted. Workplace shootings and other issues that have been averted. And finally, recently, the state of Washington has been using this against white extremist violence. So it's been an interesting implementation period, and we're just getting started as far as evaluating and looking at it and making sure that this is working properly and hopefully saving a lot more lives.
Great. Thank you so much, Josh, for that terrific, concise presentation.
10 minutes. I did 10 minutes.
You did it. You did it. One quick question for you, which is, some people say like, oh, it's just impossible with the polarization of this issue for new gun legislation to pass. And yet that map that you showed includes blue states and red states. What do you think makes it possible for this particular legal intervention for gun violence to be, so popular?
I think that, we really adhered to the data on this. We brought experts together to look at this, and I think it identifies a problem that is really rampant both in blue and red states. And one of those issues that is very resonant in red states is firearm suicide. And so in places like Colorado, Nevada, and New Mexico, I think that was the moving factor behind it, that there was such a big rural suicide issue that we and maybe even in Virginia, that we're able to, the reason I think it's successful, it's calibrated to what people need and what people see on the ground, and it affects people in many different environments, so that we were able to get more bipartisanship on this bill than anything I've ever seen. That doesn't mean that, that we get bipartisanship on every bill, but we've seen interest and implementation, even in sheriffs who say sometimes that Second Amendment sanctuaries are actually using this bill, using this law. So we're seeing widespread uptake of it across the spectrum.
But it makes it very, very specific about a situation where it's really hard to think that it's a good idea for someone to have a gun.
Exactly. Exactly.
Great. Thank you so much. All right. I'm going to turn over next to Sally Friedman. Sally.
Hello. Let me just share my screen. Okay, I think that's working. Great. Okay. Thank you, everyone. So I am going to address the overdose crisis, which sadly in the year ending December 2020 took 92,000 lives in the United States, which was a 30% increase over a similar period the prior year. So the trend is not moving in the right direction. And there's been alarming disparate racial impact as this overdose crisis has accelerated. I'll talk a little bit more about that later. And some of the main causes behind this acceleration are the prevalence of fentanyl in the drug supply and the pandemic. The good news is that there are evidence-based treatments that really do help, including medication for opioid use disorder, which is also known as MOUD, which can cut the risk of overdose death in half. There are these medications, unfortunately, and these other evidence-based treatments are often not used, which means that people who need these treatments but aren't getting them end up in various systems like the criminal legal system, the family regulation system, also known as the child welfare system, and they cycle in and out of emergency departments without getting better. And the reason for the failure to use these helpful treatments is often stigma and the perception of substance use disorder as a moral failing that's more worthy of criminalization than support and care. And these negative perceptions about people who use substances are often exacerbated by racism. So what I'll cover in my brief presentation is some legal strategies to address the denial of evidence-based care for substance use disorder in the criminal legal system and family regulation system, as well as in the healthcare system, particularly emergency departments. So I'm going to start with one of our major focuses at the Legal Action Center, which is the illegal prohibition of medication for opioid use disorder. So there are three medications for opioid use disorder: methadone, buprenorphine, which often goes by the name Suboxone, and naltrexone, which goes by the name Vivitrol. Two of those medications, methadone and buprenorphine, are often prohibited in large parts of the criminal legal system, the family regulation system, and healthcare settings, including skilled nursing facilities. And they're also underutilized in emergency departments. So at the Legal Action Center, we've been seeing this for decades, when in 2011, we issued a report about why denying access to MOUD in the criminal legal system can violate the Americans with Disabilities Act and the Constitution. And after we issued that report, we brought up two cases in New York where we intervened in two cases where judges were requiring people to get off Suboxone or face prison time. The judges backed off, but we didn't get a published decision. And I should just say, pause for a second to explain how this plays out. So in these systems, what happens is judges will tell people that if they don't get off one of these medications, they're going to be violated from probation or parole, or disqualified from participating in drug court. And if they're incarcerated, they will generally not be given access to these medications. And the same thing goes on in the family regulation system, where people are told that they will lose custody or visitation rights of their children, or be charged with abuse and neglect because they are receiving these life-saving medications, which are the standard of care, and which actually there's so much evidence showing that these medications reduce illicit opioid use, reduce overdose deaths, communicable diseases, and crime. And yet, because there's so much stigma and misunderstanding about these medications, they are routinely prohibited, as people wrongly view them as substituting one addiction for another. So back to the kind of legal context. So we brought these two cases, which was really helpful to those two individuals who were facing the loss of their liberty if they didn't get off their life-saving medication. So it was either they lose their lives potentially, or they lose their freedom. But we hadn't established any legal precedent at the time. And then in 2018, a landmark decision finally came down in the case Pesce versus Coppinger, where Jeffrey Pesce was facing a 60-day jail sentence, and he'd been successfully maintained on methadone, and he knew the jail in Massachusetts didn't allow or provide methadone. So he sued the jail and asked the court to issue an injunction requiring the jail to provide the methadone, and he won. So the federal court there issued a preliminary injunction and a decision that the jail's prohibition of methadone likely violated the ADA and the Constitution. This was the first decision of its kind in the country. And in this world, really kind of made the ground shake and caught the attention of a lot of people. And since 2018, there have been 9 other federal court cases. The 2 of them that are bolded here both resulted in favorable decisions, also with preliminary injunctions, one in Maine, one very recently in New York. And the other cases all resulted in favorable settlements where the jail or prison system ended up providing the medication that they previously had not provided. So litigation, has been one tool that we've used to advance this issue and access to medications. We also realized that we really needed to bring the big guns out. So we brought this issue to the attention of the Department of Justice and the Office of Civil Rights by telling people who were facing this problem that they should file complaints at ada.gov and on the OCR website. And we met with these agencies and explained the issue. And they then in turn kind of commenced a number of statewide investigations. They have a number of US attorneys around the country who are working on it, who've reached out to stakeholders in these systems and done a lot of education, as well as entered into a number of settlements with institutions and systems that were denying access to MOUD. So I don't have time to go through them all, but you can see whether it's jail, the family regulation system or healthcare system, the Department of Justice and OCR have really helped push this issue along. We also, skipped one. Another tactic we've been using is education and support for attorneys. So we've been working with the Ohio Public Defender in a criminal appeal of an order that someone get off Suboxone. That case is now pending before the Ohio Supreme Court. And we've done a lot of trainings and education of judges who work in these systems, all the stakeholders in these systems, as we found that people who are facing this loss of their potential life really don't have anywhere to turn because there's so much misunderstanding about substance use disorders and these treatments. So we've really found in the end that you need to do a combination of education, support of attorneys working on this issue, and litigation and engagement of federal enforcement agencies to drive change. And we've really seen the impact because over the last 10 years, there's definitely less prohibition of MOUD than there was before. And we often hear that the threat of litigation is what drives people to finally do the right thing. So a new area that we just have been diving into is emergency departments. And just this summer, we released a report that we authored with the support of the Bloomberg American Health Initiative that found that the hospital emergency departments, when they fail to provide evidence-based care for people with substance use disorders, that can negates their core role, which is to identify and address life-threatening illnesses and connect people to ongoing care. But it also can violate 4 different laws. So the report is named on your screen, and there's a link to it in the materials. And what the report finds is that there is robust clinical evidence in support of 3 evidence-based practices at the emergency room. First is to screen and diagnose substance use disorder. The second is to offer buprenorphine to treat opioid withdrawal and suppress cravings. And the third is to connect patients with appropriate care for ongoing treatment through a facilitated referral when they go back into the community, and to provide naloxone to people who use opioids or other drugs that can be mixed with opioids, such as fentanyl. So even for people who are coming in with let's say a cocaine issue, because cocaine is so often mixed with fentanyl, which they should be provided naloxone. The report points out that this is really a racial justice issue because of the disparate impact on Black, Latinx, and Indigenous populations from the failure to provide these policies, because Black and Latinx people are more likely to seek emergency department services than white people, and because the data is showing that nationally, there's a huge increase in rates of overdose among Black and Latinx people, and Indigenous people currently have the highest prevalence of opioid misuse and alcohol use disorder. There's also, if you look at local and state data, depending on where you are, you'll also see a big racial disparities in the impact of the overdose crisis. So the report concludes that the four federal statutes that are violated by not offering these practices are EMTALA, the Emergency Medical Treatment and Labor Act, which sets minimum requirements for emergency departments, which here would include screening for substance use disorder, and if an emergency condition is identified, to stabilize the person before discharge, and that the failure to do that violates EMTALA. We also found that the failure to provide these evidence-based practices can violate the ADA and a similar statute, the Rehabilitation Act of 1973, because these services are often denied, not because of any kind of legitimate reason, but really due to stereotypes about the people with the disability of substance use disorder, and that hospitals are failing to provide the required reasonable accommodation, which is these services. Finally, we found that hospitals may be violating Title VI of the Civil Rights Act, which prohibits discrimination based on race and national origin, through either intentional discrimination or disparate impact discrimination. So like I said, this report was just released earlier this summer, and we're planning to use it as another tool to drive change through a multi-pronged strategy that involves first educating hospitals and their risk management departments about why they need to do the right thing, both to do their job and save lives, but also to avoid legal liability. And we hope their patients and their allies will use it as a tool. We also think that litigation is going to be necessary, both by private litigants and in particular by government enforcement authorities. So EMTALA is enforced by the Center for Medicare and Medicaid Services, the ADA, by Department of Justice and State Attorneys General, and Title VI by OCR and Attorneys General. And so we again intend to encourage individuals to file complaints with these agencies and put pressure on them to do their job as enforcement authorities. And then finally, we hope the report will spur policy change, and such as increased financial supports for these services and adoption of evidence-based practice guidelines, more use of peer services, bridge clinics, and linkages to care. Anyway, that's actually, that wraps up I'm racing to get through my 10 minutes, Josh. I think I did it.
You did it. Thanks, Sally. That was terrific. And similar to Josh's presentation on really making a dent in gun violence, this is really about reducing the incredible overdose crisis that we have. But one quick follow-up question for you. If people are interested in this, is there anything that they can do in their community to try to make sure that the law on access to life-saving treatment is being followed?
Sure, there absolutely is, because this is a problem that really requires all hands on deck. And so people who work in the public health field can create partnerships with community groups, groups of directly impacted people, government agencies, and hospital systems to make sure that their protocols are in place to provide these services and that there's funding in place, because it takes a lot of players to make this happen effectively.
Great, thank you so much. And please keep the questions coming. We've got a bunch, but I'm really excited to turn over to Dawn Hunter. Dawn.
Hi, okay, so hopefully you can see my PowerPoint screen. And I wanted to start by expressing gratitude for the opportunity to be part of this panel. I've been a past participant sitting in the audience watching this panel myself, and so this is definitely an honor to be here today as part of this team. And I'll just say that I'm going to cover topics that are based on my own experiences and research, but also that there are a lot of experts to learn from here at the conference on some of these same issues. So I want to start with this as a foundation for you to think about during the conference. So one is that we acknowledge history. As lawyers, as policy analysts, as public health professionals, that we have a responsibility to understand how law and policy have both helped and harmed, and to understand from the perspective of those who are impacted. We have to build trusting relationships. We see that with COVID, of course, and vaccine uptake, but also historically that trust is central to effective public health. And that includes trusting that laws will be created and enforced equitably. We have to craft solutions with impacted communities, and that means thinking about the importance of co-creation, of shared vision, and shared accountability that reflects community needs and interests. And that means including community members upfront at the beginning of the process, and then also circling back at the end so that community members know that their feedback and participation was valued. And then finally, thinking about how to align with existing efforts and take collective action. There's a lot going on, right? There are task forces, there are declarations of racism as a public health crisis, there's a lot of legislation around racial equity, and we can have a greater collective impact by organizing and aligning where we do share goals and where we serve the same communities and where we have opportunities for our resources to be pooled. So how does racism show up in public health policies and practices? This is one framework for looking at this, and this is the interpersonal, institutional, and structural levels of racism. So at interpersonal level, this is what happens between individuals. At the institutional level, this is through policies and practices within institutions. And at the structural level, this is systematized across institutions and populations through policies, practices, and collective norms. So we see these three levels of racism operating in infant mortality. So if you've heard me talk at all, I talk about infant mortality a lot, but that's a measure of death within the first year of life. And there is a huge disparity for Black, American Indian, Alaska Native, and Native Hawaiian or Pacific Islander infants tied to historical law and policy that still exists today. And at the interpersonal level, so tying back to the last slide, this may look like a physician who is dismissing a Black mother's concerns about her pain or symptoms she's experiencing. But it also comes from inadequate support and coverage for services within the first year of life. At the institutional level, it looks like maybe there aren't enough Black physicians. There's a study in Florida of 1.8 million births that showed that Black babies are more likely to die when cared for by white doctors than when cared for by Black doctors. And that's also a structural issue because the lack of Black physicians today can be tied to systemic barriers like barriers to entry in higher education, but also to the closure of Black medical schools in the early 1900s due to the Flexner Report. But we know what reduces infant mortality rates on the law and policy side of things. So Title VI of the Civil Rights Act of 1964, along with other civil rights legislation, significantly reduced infant mortality in the years after it was enacted. The Affordable Care Act also reduced infant mortality rates, particularly in Medicaid expansion states. We also know the effectiveness of laws like mortality review committees and requirements for data collection, and then also education and training requirements for healthcare practitioners. So this is from a study that looked at civil rights era legislation, and the center line in this graph is 1965. And you can see a reduction clearly going from left to right on this graph. And this occurred within the context of other reforms, like the expansion in the 60s of the maternal and infant care section of Title V of the 1935 Social Security Act. And here's a fun fact: Medicaid expansion states are required to cover the 10 essential health benefits, which includes maternity and newborn care. And prior to the ACA, insurers did not have to cover these services as part of standard plans. But another thing about Medicaid expansion is that nearly 60% of uninsured adults in non-expansion states are people of color. But let me tell you that we are not 60% of the population in these states. So this is a graph from the Center on Budget and Policy Priorities that looks at who stands to benefit from Medicaid expansion in states that are kind of holding out. And you can see clearly that it's Black, Hispanic, and other people of color in these states who would benefit. The American Rescue Plan is incentivizing states to expand Medicaid by providing money and flexibility. And despite this, states are still not taking action. But in addition to reducing disparities, there is a significant economic benefit to expanding Medicaid, which also impacts disparities. So in one example, I looked at North Carolina, and there's an estimate by the Kaiser Family Foundation that Medicaid expansion in North Carolina would give the state a net gain of $1.2 billion post-expansion. So what else has an economic benefit? Raising the minimum wage. And there's a lot of research to support this. But raising the minimum wage does a lot of great things that we know about. Two important things are reducing poverty and income inequality, and then improving infant health and reducing infant mortality. So this image here is from Florida's Amendment 2, an analysis of Florida's Amendment 2. Florida's increasing the minimum wage up to $15 an hour, starting with $10 an hour on September 30th of this year. And this study looks at who stands to benefit. And you can see here that it is mostly Black and Latinx employees, but also Asian American and white employees and low-wage workers in general. So what are some current legislative trends? I've been looking at bills that include the terms listed, so racism, racial equity, or health equity, and I've divided them into these 9 issue areas. And so there is some continued focus on equity and birth outcomes. You may have heard of the Momnibus Act being introduced in several states. There are bills around data collection and use, obviously connected to COVID. There are some bills around provider education and training as well, particularly around cultural competency requirements for licensure or relicensure of healthcare professionals, which is not required in most states. And then additional requirements like implicit bias training. We're also seeing racial equity impact assessment requirements for legislative analysis. And then the two that have stars here are two that I've spent a lot of time on here at the network, along with some of my colleagues. So looking at the more than 200 declarations of racism as a public health crisis or emergency that have been introduced across the US, state legislatures have been looking at these as well, and we expect we'll continue to do so in 2022 sessions. And then COVID task forces. So we saw at least half the states set up a task force related to addressing COVID-related health disparities. And so there has been some legislation introduced to formalize these task forces. And I'll also note that there is a lot of overlap in these task force recommendations and the declarations of racism as a public health crisis and in other non-legislative actions, so across these same 9 issue areas. So to revisit my earlier slide, how does racism show up in public health policies and practices, and where can law and policy make a difference? That is tying the legislation to the different levels of racism that I mentioned earlier. So at the interpersonal level, that's provider education and training requirements. So there's research to show that being able to communicate with your clients effectively helps to have better outcomes. At the institutional level, that is increasing workforce diversity by reevaluating HR policies or by incorporating community feedback into programming decisions and investment decisions. That's strengthening the local public health authority and infrastructure at the structural level, and also identifying and removing legal barriers that impact access and opportunity. So, sorry, I've got a blocking my screen. Okay, so in practice, what does this look like? If you were on a recent NGA webinar that I did, you saw this, but this is just one, I think, really good recent example. The Washington Post published a detailed account of FEMA's policies in July and noted that FEMA was regularly denying claims to Black families who live on land that is passed down informally without a will between generations. A Jim Crow era policy on property ownership. This is also known as heirs property. FEMA required proof of land ownership in the form of a deed or a will, but about a third of Black owned land in the South is owned via this heirs property. So this recent policy change was significant because it allows more options to provide proof of ownership and reduces barriers to federal disaster relief funds for Black families. But it also affects Hispanic people, like in the Colonias in the Southwest, American Indian people, and rural white people in Appalachia. So coming to wrap this up, what do we need to do now to ensure more equitable outcomes in the future? Here are a few suggestions. We can formalize commitments to health and racial equity, and that includes through declarations of racism as a public health crisis, through these task forces, and through other legislation that create an infrastructure that supports more equitable outcomes. That legislation is informed by data, evidence, and subject matter expertise, that we systematically and regularly review policies and laws using an equity lens. And so I worked in a health department, and we said we need to be, and as part of an accreditation standard as well, we need to be regularly reviewing our organizational policies. Allocating sufficient resources, of course, monitoring the impact of laws and policies on health outcomes over time. And perhaps to me, the most important is engaging communities in the policymaking process and equipping community members to lead. And I hope that you will see these themes carried out in throughout the conference and some of the sessions that you'll attend. So I want to end with this and revisiting my first slide, which is that we have to acknowledge the history of the fight for racial justice, and that the work to achieve health and racial equity was amplified by the pandemic, but it existed long before, and the communities that have been working for a decade or longer, and really decades throughout our history as a country, to achieve racial equity. And so recognizing that history and where it brings us today. And I want to encourage us all as public health professionals and practitioners to think about being vulnerable as individuals and as organizations and as partners in this work. So thanks, and I look forward to questions.
Well, that was really super. Thank you so much for that great presentation. I have one quick question for you, Don. I know that you've been working recently on some issues involving voting, and I wonder if you could just comment on how voting relates to the issues that you spoke about?
Oh, I would love to talk about that. So thanks for asking. So we recently, as part of the Healthy Democracy, Healthy People initiative, launched the Health and Democracy Index. And it's a way of visualizing data that shows us the very clear connection between voting and health. So basically, states that have less restrictive electoral environments have better health outcomes, and states that have more restrictive environments have worse health outcomes. And we see this very clearly with mortality rates, with poverty, with overall health, so self-reported health, like whether or not the population is healthy. And this is important because we know that voting and health disparities are linked. So, voting really shapes the conditions of our lives, and it shapes who will be a future voter. So when we have disparities in turnout, that means policies reflect the interests and needs of the people who turn out to vote, and not necessarily of everyone else. And that can basically turn into this cycle where people don't get to vote on the policies impact their health outcomes, and then their health outcomes determine whether or not they'll vote the next time around. And so it's really important, I think, to understand this connection, that us being not just voting, but being engaged civically, being engaged in our communities, volunteering, and other forms of civic participation are a really important part of how we remain healthy as individuals and as communities.
Great, fantastic. Well, we're going to turn to some questions that have been coming in. Dawn, I want to actually ask you the first question, since you were the last presenter. And that question has to do with, there's obviously a lot of things that are needed to advance racial equity. There are a lot of things that can fit under the umbrella of addressing structural racism. Where have you seen the most initial progress? What is gaining the most traction under, different resolutions around racism as a public health crisis, or other work that is about racial equity? What substantive areas seem to be out in front?
And I guess I would just re-emphasize that one of the first and probably most prominent and important is more meaningful and intentional ways of engaging the community in the policymaking process. So finding ways to really have policy reflect what community interests are, and have partnership in designing solutions to problems that are collectively identified, and then doing collective implementation. So I think that focus on the community is really important. And then there is also a lot of movement on addressing some things that are specific to COVID. So looking at ways that we can better collect and use data on the disparities that exist in communities, that's something that we see quite a bit. And also healthcare access. So we've seen that during the pandemic, but also thinking more about, is the pandemic and the disparities that have been really amplified teaching us anything that we can do to make changes to our healthcare system that improve access for everyone, but particularly for people of color and other groups that have historically had more limited access. And then I would just say that one of the other big things is thinking about how to do things that are actionable. And so we're seeing, especially with declarations, people trying to figure out how to create racial equity plans. And so there are some different examples of that from across the US of collectively creating these plans and trying to find ways to implement them in a way that will advance, meaningfully advance health and racial equity in these communities.
Got it. So it sounds partly like there's a strategic moment with COVID to have people see what's going on there and use that as an early step to get people to pay attention.
Yeah, I think if people don't know where to start, because you say, well, how do I address racial equity? And it sounds like this really out of reach thing. But I think you start with things that are important and relevant to your community. So if your community has struggled to have the data available to tell you how the pandemic is impacting people, start there. If you live in a community that is experiencing a high degree of food insecurity and you want to find ways to make sure that people have access to food, start there. So it's really about kind of just even some ways being hyper-local and saying, what's going on around me and in my community that we can just address now that we know that we're having huge disparities in. And then that is also just, those problems exist all across the country.
That's great, thank you. Josh, I wanna turn to you next. Question about the resources for working on gun violence. And the question came in about research resources, but also let's just throw in there advocacy resources. This has been a hard area because of the strongly held polarizing feelings people have on this issue. What's the landscape like now?
So it's a lot better than it was. It's not perfect by any stretch. So first of all, there's been, because for many years, there was an amendment that called the Dickey Amendment that prohibited CDC and others from providing federal resources on this. There's a sort of a limited amount of research on this. That amendment, especially with the Biden administration, has really been newly interpreted, and there's a lot more resources at the federal government, at the federal level for research. So there are CDC grants, there are NIH grants, there are IMH grants that are starting to look at issues of violence. And so there's not nearly enough funds out there, but it's really starting to flow in different ways. The other thing is that there's the private sector has really stepped up. And so we're seeing more money, especially, for instance, there's a new initiative from RAND with some major financial backing from some private foundations that are starting to spend more money on research. And of course, there's some stalwart foundations like the Joyce Foundation, the California Wellness Foundation, and others who have been out there funding this for a while. So we are still at a deficit situation, but we were just looking at that today. There's a lot, I mean, far from when in 2003, the National Research Council, I think, looked and said, hey, there's not enough evidence here to make a conclusion. There's a lot more evidence in the last 15 years. And if you look at our Consortium for Risk-Based Firearm Policy Twitter link, you'll see new research coming out literally every week. However, there's a lot of ground to make up. There's a lot of things that we still don't know. And it's, I think, a very fertile ground for research, and there are more resources being available every day.
Great. Sally, I have a question. The work that you've done laying out the legal obligations of different organizations, could be jails, prisons, now hospitals, emergency departments. The actual enforcement of those rights sometimes take, or those standards can take quite a long time. How do you think about the time scale of change when you're looking at the potential for the justice system to be the lever as opposed to, say, legislative action? What can be done to accelerate that?
I think it has to happen on multiple fronts. You certainly can't just rely on the kind of justice system or the legal system to take this to where it needs to go. So I think that people have to use multiple strategies, and to get to this stage of like universal adoption of these practices and all these systems is going to probably take a very long time. But there's been a lot of change in the last 10 years. In my I'm not that old, that I can remember not that long ago, when I, for example, in jails, I used to say I could count on one hand the number of jails in the United States that provided medication for opioid use disorder. And that picture has changed substantially in the last 10 years. Now, of course, that change isn't fast enough because many people have died during that time because of these failed policies in the past. But I think that there's a lot of momentum now for change, especially kind of propelled by the overdose crisis, and not just opioids, but other drugs as well, which are killing people. And increasing recognition of addiction as a disease that can't really just be addressed through criminalization. So I think that and there also has been a huge push to integrate substance use disorder care into the healthcare system generally. It's a lot, change is slow, but I think that change has to happen on multiple fronts: education, policy, advocacy, people exercising their legal rights. I think it has to happen on all of those fronts.
Well, that's good, but knowing that the law's on your side is a nice thing to have for those other types of advocacy too.
It absolutely helps a lot when you're engaging in education, whether it's of policymakers or of judges or hospital administrators, to explain that this is crucial to save lives is obviously part of the equation, but then to say that you could be held liable if you don't do it is also helpful.
Great. I want to ask a question for all three of you, which relates to the example that Dawn gave about the policy on African-American farmers. And how is it possible to uncover examples of things that not only are wrong, but so clearly wrong that they galvanize action? And what can organizations do in their own organization, but also looking to other places? What are other places to go and how to do that work? I think this is relevant to both Sally and Josh. Sally, in part because there's a question people may have about, well, what is the policy of the local jail or the hospital? You know, how do you uncover the present state and the unsatisfactory nature of policy? And, you know, for Josh, I would, you know, reflect that sometimes in the wake of shootings, there's all of this discussion about how policies were implemented. How do you draw the connection between that to what kind of legal change that you want to have? So, you know, in part, we're advocating for changes in policy and law based on demonstrating failure. How do you demonstrate failure? How do you find those things? Don, I'll start with you.
Yeah, so I'll give two quick thoughts. So the first is I like to do an exercise called the 5 Whys. So some of you may have been involved in an exercise with me on that, but I think that it's not enough, right, to collect data about how things are impacting different populations. We also have to ask why. So in the case of like the FEMA example I gave, if we know that we're not distributing funds as an organization, we're not distributing funds in the way that we think we should be, or certain populations aren't accessing those funds or resources, we should be asking why and start to look at what are some of the underlying reasons for that those problems with access. But I think that goes to the second thing I want to say, which is that we have to give the people a voice for their experience. So what we think may be the problem and the barrier in access may not be the same perception from the communities from a community perspective of what the problem is. And so I think we have to do a better job of providing an avenue for people who are impacted to share their experience and their thoughts on what the problem is and some potential solutions.
Great. Sally?
So how can communities find out what's really going on in their community? I think listening to people who deal with those systems and hearing their stories, I think, is where people should start. And then I think, you know, in the case of evidence-based practices, people can just ask those institutions. They are generally unabashed about their policies and practices. It's not like they're trying to hide it. So I think people should, you know, call up their local emergency department and ask what their protocols are when someone arrives at the emergency department with a substance use related emergency. What are they doing? Do they have protocols in writing? You know, contact a local jail or a prison system and ask. Again, people who don't provide these practices often think that they're in the right and that they don't need to. So I think it's not so hard to find out. And then, you know, in terms of identifying the disparate racial impact, though, which is hugely important, data is sometimes available and sometimes it isn't. So people need to kind of dig for the data where it is and then put pressure on institutions to collect and report out data when they're not.
That's a great point. Josh?
Well, one of the things we did to tie back to the extreme risk protection order is we spent a lot of time talking to people with mental illness or people who represent people living with mental illness. And we realized that the stigmatization of gun policy focused in that area was incredibly harmful and stigmatizing. And so we wanted to be able to pull back the data and look at what was really going on there. And so we heard these stories, we heard these cries, and then you look at the data and it actually verifies what we're hearing, that stigmatizing people with mental illness by focusing firearms prohibitions distinctly and only in those areas is not going to get us very far. So it's a mixture of listening to stories, identifying the problem, and seeing if you can verify that with the data. And so the extreme risk protection order was an example, we think, of mental health equity, designing a civil protection order, listening to the stories of people who said, don't focus just on us because we have a diagnosis. Doesn't make us violent. Most people with mental illness will never be violent. So it's that narrative and that data working together to create a policy that we think saves lives without stigmatizing folks.
So just to follow up, Josh, how would someone try to figure out what policy is operative in their area to see whether it is a policy design like that or what the rules are about gun removal?
Two ways. You've put the Bloomberg American Health Initiative website in the chat, and so that's a really powerful website. It will have all of the information, very detailed about extreme risk protection orders in your area, as well as domestic violence protection orders. And the other place to go is to our website, Educational Fund to Stop Gun Violence, EFSGV.org, and there's a map there with resources as well to find out what policies are there.
Great. Okay, I'm going to keep going with questions and we'll go back to you, Dawn. There are a number of questions asking you to speak a little bit more about the resolutions declaring racism to be a public health crisis. And if you could maybe explain a little bit more about what those are and where you think they are having the biggest impact.
Yeah, so the first I would say is these declarations are statements of intent. Right, their intent to address the problems of racism from a public health perspective. So looking at it from a systems perspective, recognizing that structural changes need to occur because it impacts large populations over time, right? That's how we're defining it. And so these are important because the declarations do a couple of important things. So in addition to giving us a clear statement of commitment from the policymaking body, they're a mechanism of accountability later to go back and say, did you do the things you committed to doing? They also lay out a framework for action. So a lot of these declarations will say they're going to assess policies through using a racial equity lens, or they're going to look at their budget process, or they're going to create a new office or position to help advance racial equity in their community. So again, we can go back and say, did you do these things? And the other important thing that these declarations do is they bring attention to the issue. So I think that's half the battle, is saying, you know, we have contributed to the problem of systemic racism by our own intentional policy choices, and we want to help remedy that problem. But also saying we're not going to do it, you know, for you. We want to do it with you, and we want to, you know, lift up community voice in that process. Actually, I think, you know, when Josh was just talking, I was thinking about one really good example across different cities and counties is community conversations. So this is where health departments are equipping community members and leaders with the tools to host like town halls with policymakers. And then the health department is stepping back, right? So the people who are running it are the people in the community, and they're the people who get to, you know, have these conversations directly with policymakers on issues that are important to them. And so that's one way to uncover what's important to the community, but also to engage, you know, to encourage more engagement in the process. And so these declarations have really helped facilitated some of these activities. They facilitated these different kinds of town halls, and they facilitated a real critical look at the way that we collect and use data, and thinking about training. And of course, we've seen positive and negative about the kinds of trainings that are required, but we do know that there's a lot that goes into having implicit bias training and cultural competency. And so we need to find a better way to have conversations about their value. But that's kind of a big overview of what these declarations do.
Josh, can I jump in there for a sec?
Sure.
Don, one of the things that we did early in this process and continue to do in almost every state where this passes was that town hall situation. We called it a forum. We brought the academic experts, the policymakers, and the community together to share ideas, to share concerns. And it really was one of those places where you learned a lot and listened a lot, and policymakers were able to listen and learn. And so I'd like to do it even more, but it was an incredibly important tool in the policy development process.
Great. I want to ask a question that I think is relevant to all three of you. This is a very difficult time for public health for many reasons. It's been a truly horrific and exhausting pandemic. And as we know from the great work of the National Network for Public Health Law, there are all kinds of different attacks on public health officials, on public health departments, on the legal basis for public health authority. How do you see that playing out, or the implications of that for the work that you're talking about in these three different areas? And one specific question, I'll start with you, Sally, is it going to be harder to declare overdose a public health crisis if public health departments aren't allowed to declare anything a public health crisis because they've had their legal authority stripped? Is this, you know, how much is at stake with this overall battle around public health?
I think that the kind of backlash in the country against public health mandates it's very different than what goes on with the overdose crisis. But one thing that's similar is that I would say is the disregard for science. So, you know, the fact that judges, you know, disregard science and force people off, you know, effective medication or threaten them with prison time instead, I think has always been a reflection of kind of a skepticism about science in favor of ideology. So I think that's what's similar, but I don't think that the backlash against public health in terms of COVID, is going to kind of set back efforts to address substance use in the same way. I hadn't thought about it to ask the question, but I'm not seeing that.
I want to pull on the thread that you have there about science. How confident are you, as these cases get appealed, that the legal system will stand up for science and not fall down? Because we're seeing on public health sometimes some very serious appellate courts within states saying and doing things that are real head scratchers.
Yes, I'm not totally confident, depending on where the case is and which judge gets the case, that the judge who's deciding an appeal will follow the science. I don't think we can be totally confident of that. So far, it's happened in some of the litigation, but not in all of it. So I think that also feeds into your litigation strategy and kind of where you file your lawsuits.
Got it. Josh, any thoughts about this? Have you been seeing this at all?
Yeah, so I think, for me, I see the COVID battle and the voting rights battle mirror a lot of what we see in the gun violence issue, which is a group of people who are not following the science across a whole bunch of different areas. And in some ways, public health, for some people, it's more motivating than ever. What we see right now, and you just see it in the Johns Hopkins COVID tracker site, the traffic that gets there, the interest in solutions, all that kind of stuff is, I think, at an all-time high. But the opposition now is very base and very and is really entrenched. And I do worry that in states, especially states that are red right now, that this is all going to be melded together: COVID, voting rights, guns, in a very cultural component. And so I don't have a great answer to this, other than this is that working in the middle and making sure getting people who, I wouldn't say are totally skeptical, but getting people educated on the science. You're starting to see that's like slow uptake in the vaccines. You've got to reach out to that group, because there's some people we're just not going to reach, but there are reachable people, and getting those people is extremely important. I do think science and data matters there.
Great. So Don, question for you. We have so many, health officers who are been pushed from their jobs, quit, have been fired. How does that affected this movement to pay more attention to racism?
Well, I mean, at a high level, I think part of it is you're dealing with challenges of to your authority, and you're dealing with COVID. I think one of the things that we have heard most frequently is that I don't have time to prioritize racial equity. And I think that matters, because what we hope people evolve to is thinking about equity throughout your entire organization and process and all the work that you do, that it's not a separate task, that you can respond to the pandemic in an equitable way. You can think about how to uphold public health authority in a way that also ensures equity. So I think that's probably the start. And I appreciate Josh mentioning voting, because I think the attacks on elections officials and the attack on public health officials are related. And I think at a very high level, it's about institutions feeling like they're under attack, and they're trying to preserve, right? So legislatures are taking action to preserve the institution, whatever that's defined as. And so I think that we need to have more conversations about what is motivating some of these attacks. So what is behind these challenges to public health authority? What do you really want as a community? I don't think it's safe to assume that just because people say they don't want to wear a mask, that it's just simply about freedom. But what does that mean? How is that defined for the people who are bringing these challenges? Same thing for racial equity. I think, how do you define racial equity? How do communities define that? And what do different people and communities and organizations want? And then I guess the last thing that I'll say is that we really need to also do a better job of communicating about the value of public health independent of the pandemic. So people understand injury prevention. People understand, that we keep the food and water supply safe. Like, people understand our role in helping to address hunger and help and ensure healthy moms and babies. And so I don't know that right now we're doing that, because we're spending so much time responding to, from an emergency preparedness perspective, to things we need to do to control infectious disease right now, that we're really losing the information war on the value of public health in general.
Yeah, these issues, in other words, are not so divorced from the overall challenge facing public health. Let me pose a question to all three of you that has to do with implementation. So you have the legal reports, you have the laws pass, you have the resolutions pass, and then what happens next? And Josh, you talked about a project to really make sure that this gets implemented. Maybe I'll turn to you first, implemented well. Can you just give an example of the difference between a well-implemented extreme risk law and a not so well-implemented law, why this matters, what kind of engagement public health lawyers and others need to have to follow this through?
Yeah, that's a great question. That's a great question. I think there's a number of examples of success we've seen, and they all have to do with finding a champion, someone who really cares about the system and knows how to move what I call the system actors around. So implementation, for instance, in Seattle, King County, is the development of a pilot program that was successful, and then getting county and city funding to really build out a joint DV extreme risk protection order unit that includes survivor and DV advocates, prosecutors, law enforcement, judges, but judges aren't part of the unit, but includes a unit that looks at each case holistically, because you don't want to just sort of, someone comes in and says, I need an IRPA, we should do an IRPA, or law enforcement comes in the door. You want to look at, is this the right solution? How do we remove a firearm without creating more of a problem? So one of the things that great implementation does is what's called warm service, right? Someone's in a crisis, you don't want to go in with SWAT team and all that kind of stuff. You want to make it as easy, friendly as possible, right? So having that sort of deliberative process around it really matters. Go to Fort Lauderdale. One of the students from Bloomberg American, I think is a Bloomberg fellow, Chris Carito, runs the extreme risk protection or unit at the Fort Lauderdale PD. He takes a big interest in the person, the family, the structure, and he's able to remove firearms when it matters without creating further harm. And that's been, I think, true in a number of different states. When you turn to New Mexico, for instance, New Mexico is a state that's low in resources. They have a big need. They do have an extreme risk protection order there. We have great advocates on the ground, but we don't have a champion within state government who's able to go ahead and say, I'm going to organize the resources to put this together. So it's really, and there's some really good practices around that, and we're really trying to spread that to places like New Mexico, but you have to be deliberative. And one of the things that we've heard over and over again is resources matter. So in a place like King County and Seattle, they have resources to develop a sophisticated unit. Right next door in some of the more rural counties, they don't have it and they're looking for it. So I think there's a role not only for experts to come in and say, hey, do you know what you need to do? And that's where lawyers and public health professionals come in, but also on the policy side, do you have the resources you need, especially in rural counties where suicide is high?
Yeah. Maybe
Can I
Donna.
jump in?
Sure, absolutely.
Oh, sorry. I just wanted to jump in on your Seattle and King County reference, because from a racial equity perspective, Seattle and King County are one of the areas that have am I frozen? Was I frozen?
No.
Okay. Seattle and King County are one of the communities that have really been at the front of racial equity work and incorporating racial equity throughout governmental operations. So they're doing all the things that we want communities to think about doing. So putting adequate resources toward the work, incorporating racial equity tools into budgeting, into programmatic planning, into their strategic plan, and throughout their workforce. And so I think that's just a wonderful example of what it can look like once you have been putting in the work. But I think for people who are just starting out, or communities that are just starting out, I would say it's important to realize that you're not going to affect change in the community until you work on yourself. It's probably a life lesson for all of us as well, but do a self-assessment first about your own biases, your own prejudices, the way that you operate in the world, and then within your organization. And then as an organization, the organization has to do an assessment too. How are we perpetuating disparities in the community we serve? I've always thought of public health as being this institution that does good things in the world, but that's not always true. There are things that we do that have been harmful. And I think we have to really just take stock of our own actions as organizations that have created disparities that we see today, and be more meaningful about how we address them. So starting self and organizational assessment before we start going out and trying to fix things in communities.
Do you think sometimes those things have to be done in parallel?
I think they can be.
Yeah, how do you balance that?
I think they can be done in parallel. I think, again, you know, so Josh was talking about having a champion. I think you have to have champions for racial equity in your organization. It definitely has to come from leadership, but it also has to be something that your entire, you know, your workforce is behind. But it's really hard to do that if you haven't had your employees really think about where they fit on the chain of helping to advance racial equity. So I do think you have to start there, but I do think you can also start to develop plans, and there are lots of tools and resources out there to help communities figure out how to engage in the process of developing racial equity plans and analyzing laws and policies. So that can be done. But understanding that you don't have all the answers up front. And that's what I meant by saying we have to be vulnerable and just say, we don't know it all, but we're going to learn more, and we want to learn from each other. And we want to learn from you, community members.
Right. And in the process of introspection, you may learn some different ways of engaging and ideas for making progress. Sally, thoughts about implementation? And, you know, the risk is that somebody reads one of your reports and does something really the bare minimum, you know, to try to convince a judge that actually they're following the law. You know, we make these drugs available, but just turns out that we never actually prescribe them. You know, how do you think about implementation compared to the obligation that you think exists?
I think some of what other folks have said applies equally in this setting. So resources obviously are crucial. So is having a champion. I think having peer institutions do the right thing and learning from them is also hugely important. I've seen that in the criminal legal system context, where there'll be a judge who didn't believe in medication for opioid use disorder. They were somehow turned around, and whether they were forced to do it or whatever, and then they saw the benefits to it. So then they have been spokespeople for the cause and convinced other kind of reluctant judges. And I think that hospital emergency departments also can learn from those. There are many emergency departments in the country that are doing the right thing and that are adopting these evidence-based practices. And they are seeing in some instances, there's less cycling in and out of emergency departments by people with substance use disorder. And I think that they have a lot they can teach those hospitals who are not. Are you ever going to have everybody doing it, you know, fully to the best extent possible? No, but I think all of these things help push people along.
Got it. Well, this has been such a fascinating conversation. You know, there have been moments over the last year and change when it's been pretty difficult to see bright spots in the public health landscape. But I think all three of you really spoken in depth about things that can be done at the local level, at the state level too, that really can make an enormous difference and are actually moving forward. I mean, this is a moment of progress in all three of these areas. So I'm personally inspired, and I think as we start this fantastic conference, I want to give each of you like a moment for a few closing thoughts, but you know, maybe focusing on the inspirational, focusing on, you know, why this is what we can say to people who have been discouraged and frustrated over this really, really difficult period. Maybe I'll start with you, Dawn.
So the first thing that came to mind when you started to pose that question was, don't let the perfect be the enemy of the good, right? Is that there are a lot of racial equity tools out there. There are a lot of approaches to take. You can spend a lot of time trying to go through these and research them and analyze them and try to pick out the right thing to do. There is no right thing to do other than to make the commitment and act on it in a way that advances equity. So pick one of the tools and start working with it, and go out and start meeting with community members. So I would say, whenever I feel overwhelmed at work, I might have this, I put all my things I want to do on Post-it notes, and I might sometimes feel overwhelmed by how long the list is. Then I just say, okay, pick one activity at a time. I'm gonna work on that and I'm gonna finish it. And I think that, you know, from a racial equity perspective, like I said earlier, it can feel overwhelming to think about how do we address this historic problem. Let's start small and start in our communities and start by looking at around us and where we operate in our local governments and schools, et cetera. And then we can start to expand that out to a higher structural level. So it can be done, and pick a place to start and focus on that.
That's fantastic. Thank you so much. Josh.
I recently had a law enforcement officer say to me, "You public health geeks, you got it right this time with this thing." And I think that was important. There was a tool that was missing that was not in the criminal justice arsenal. And I think it was the use of civil protection orders. And sometimes thinking hard about issues, applying two things that really matter to me in my organization: the public health model and an equity lens to everything. Really makes a difference. And I really believe that, I started at the beginning by saying, dream about what can be. And I think if you apply models, and public health is one of those, I think equity is another one of those, but dream about what can be, where you can take policy and go out and try to make it happen. It won't happen perfectly every single time, but you can, even in difficult issues, we can make change. And I truly, truly believe that the public health professionals in this room, using the framework that Dawn has laid out, that we have laid out, that Sally and I laid out in public health, there is change to be made in important ways. And as difficult it is in public health now, in some factors, I think there's an increased knowledge that this is the way forward. So I'd encourage you to dream big, work with communities, and get something done.
Fantastic. Sally.
Yeah, I say that, we're kind of where I started, which is as horrible as the overdose crisis is and as addiction is, there are healthcare strategies that work and they are based in evidence. And I, in the last 10 years, have seen many people who don't believe in them and who've not used them kind of switch. And because these strategies are so effective, they become, sold on it and can then become champions for that issue. And so I think that while there's always going to be somebody who you can't turn around, I think that this is a fight that's totally worth waging because we've seen results, and I think we'll continue to see more institutions kind of embrace evidence-based policies and save lives.
That's great. Sometimes, on a bad day, you think of something, you go, oh, that's another thing that's never going to happen. But you shouldn't think that way. And all of you have really just done such a fantastic job setting out a vision for legal tools, policy, law, to really make a difference at this really critical moment for this country. So I really want to thank you all, Dawn, Sally, Josh. Thanks for getting this conference off to such a great start.
And thanks for having us.
Thank you.
Thank you, Josh.